All right, so this is Erika. Some of you have met her as she's been very active with our community. She has her PhD in neuroscience from the University of Guelph, and she's currently working as a research associate in the Neurocognition Mobility Lab at the University of Waterloo. Her research interests include understanding the sensory feedback in the skin on the foot sole that is generated by contact and loading in walking. So, peripheral neuropathy is a loss of sensation that is commonly observed in people with Parkinson's, which compounds the balance deficits. Some of her work is examining methods to enhance skin feedback in order to improve balance. This webinar introduces peripheral neuropathy in Parkinson's and how it impacts gait and mobility. Learn about footwear and foot care practices to maintain foot health. Okay, Erika, I'll stop sharing my screen and turn it over to you.
Wonderful. Thanks, Robin. Sounds like you can give the talk. I think you're well on your way with that description. So thank you very much. All
No problem.
right, let's see. If I can share, let's do this first.
I have to stop
Um,
sharing first.
Stop sharing first, right? Yeah, this is where, okay.
Sorry.
So I should be able to, no, let's say it's the wrong screen.
Just
This
bear with
is
it.
inevitable tech
Yes.
tech challenge. Okay. So if I is
Did I stop?
here, and then I do, this is what I wanted to do. You should be able to see my slides.
Yes.
Okay. All right. Well, thank you so much for inviting me to come and chat today. Um, and I thought I would bring in a topic that sort of melds my two worlds a little bit more. And so I'll jump right in. There we go. All right. So, as Robin mentioned, my name is Erika Howe. I spent actually all three of my degrees at the University of Guelph. So I sort of was there for a long time and connected with my supervisor, um, and stayed along for my master's degree. And then I actually went and worked out in the community for a while as a registered kinesiologist. And in that time, um, I was providing um, lifestyle implementing strategies, providing education, particularly around falls prevention education, and facilitating exercise in older adults and those living with chronic conditions in order to reduce falls. And then I actually was working, I kind of got into the diabetes management world, and I was using exercise as a pillar to manage diabetes and blood sugar control. And kind of that brought me back full circle to go back and do my PhD, where I looked at sensory information from our foot soles and how it relates to balance and posture control, and how blood flow plays a role in sort of modulating that sensory sensitivity. And that's all to say is that I'm now graduated from my PhD, and I've been working with Dr. Kaylena Eagles-Martins at Neurocognition Mobility Lab at Waterloo since earlier this year. And so many of you are familiar with Kaylena and her work, but she is the principal investigator of the lab and a Canadian research chair at the university. And here's our sort of current study team. And so a lot of our research interests are really trying to find new ways to preserve mobility as we try to understand better how our brain controls our walking and balance. And a lot of our work is specifically in the Parkinson's world, although we look at some healthy aging and other neurodegenerative disorders like functional movement disorder. And so, you know, some of you, I see some familiar faces, and some have maybe been a little bit involved in some of the work that we do, but a lot of the work that we are looking at now is the interaction of gait and mobility in Parkinson's, but how stress and arousal can impact those two things. So it was a bit of a jump in terms of my formal training and coming into this world. The connection for me was getting back into sort of more clinical patient front research rather than very basic mechanistic science where with my PhD work. And there was this sort of untapped sort of cornerstone at the moment with some sensory information and looking at how sensory information is integrated and impacted by Parkinson's. So I tried to sort of take a little bit of what where I came from and where I'm headed, where I am now, and thought we could sort of take some time today to talk a little bit about sensory contributions to motion and what happens when it gets impacted with things like neuropathy. So we'll start off a little bit with talking about skin and its role in mobility, some of the tribulations, and a little bit more about neuropathy, but specifically neuropathy in Parkinson's and what we understand now in the literature of where the links are. And then we'll try and end with some practical tips of how we can take care of our feet. And then, of course, I'll always do my little elevator pitch of some of the upcoming research and ongoing research that we have now, because as you're very well aware, we can't do the research without wonderful folks like you. And so, having your involvement is critical and pivotal to moving forward with our work. So I invite you to take a walk with me, not literally, because of course we're stuck in these, chairs as we listen virtually, but when we don't really think about walking in ways it's automatic. We just put one foot in front of the other. But have you ever really stopped to think about what it takes to get ourselves around and what senses are involved to help guide us? So our vision will help us make a plan about how to avoid obstacles or other people. We have our inner ear or our vestibular system that will give us information about linear or angular accelerations, which is really important in terms of remaining upright against gravity. But then there's, taking the time to think about what do our feet tell us every time that we take a step, and where does that information really come from? And so it's the role of skin, specifically skin on the bottom of the foot sole, that is the direct interface with our environment. Within the layers of the skin, we have tens of thousands of receptors, specialized receptors that can encode for dynamic types of information such as slips across the skin or when our foot is in contact with the ground. We also have other receptors that can tell us more static or prolonged types of inputs, such as pressure and stretch. And so together, these sensory endings can be used to help us balance and allow us to react and understand the surface below our feet and how can we modulate our movement as a response to that. So in quiet stance, you can think of our skin receptors sometimes as almost like a pressure map, right? So as we lean our toes towards, as we lean, so forward, the center of gravity moves forward, the pressure accumulates in that region of the foot sole, and we have this reactive response in order for our muscles to turn on and activate and bring us back to our center. Because, of course, if our center of gravity goes sort of beyond that base of support, that's when we lose our balance. So we have this sort of cat and mouse happening all the time. Similarly, right, when we lean backwards, that pressure accumulates in our heels, and we know then to activate some of those muscles on the front end of our bodies and be able to move forward. So in more dynamic situations like walking, skin receptors can also detect, things like slips across the surface to generate appropriate movement responses even in our upper limbs, right? So reaching for a grab, and grabbing onto a handrail or bracing ourselves. So the information from the bottoms of our feet is continually telling us where we are within our sort of center of gravity and providing us that map to give us, how can we react appropriately. And so the scan information is typically, unconscious process of interpreting these sensations. And most of the time, it's used in a very sort of reflexive manner, and very fast. So before we're even really consciously aware of it. And so, how can skin modulate our movements? Actually, so this is because skin receptors, they synapse or connect onto the motor neuron pool. So motor neurons are the neurons that to go from the central nervous system to our skeletal muscles to generate contractions and tell us when to contract and move our muscles. So there's actually direct connections from skin receptors that go up into the spinal cord, and they project onto these muscles of the lower limb. And what it does is it can effectively modulate the excitability of the spinal cord. So you can almost think about there's sort of this baseline level of excitability. And when we get to a certain threshold of excitability, those neurons will turn on and will sort of contract that muscle. And so what we can do is some of the theories is that skin receptors almost contribute to this sort of gain mechanism where they can bring the spinal cord sort of a little bit closer to firing threshold, so it makes it easier for them to turn on. But effectively, our skin can help change the way that we move. And of course, we normally think of our movements as commands from our central nervous system for volitional or voluntary movement, right? My brain says I want to grab this cup. So I'm going to go and grab this cup, and I'm going to turn those muscles on in the appropriate way to make that sort of happen. But we need to have these, independent spinal circuits that don't involve central processing within the brain in order to have the ability to have rapid responses and respond to things like perturbations. So a classic example of reflexes is removing your hand away from a hot object. That motor response actually happens within tens of milliseconds. And so it's much quicker because in fact, while that sensory information gets activated here within the foot sole, it also sends a copy up to the brain for central, sort of sensory processing. And so in fact, the perception of hot isn't consciously perceived until nearly 500 milliseconds, which still might seem pretty fast, but imagine how much more damage the skin would undergo if we had to wait to feel the pain and then withdraw away from it. So there's, these spinal circuitries exist so that we can react. So similarly, if I was walking along and I walk through my living room and I step on one of my kids' pieces of Lego, I'm sure you've all been there. It's not a pleasant feeling, but I'm able to withdraw away from that painful stimulus. And, prior to even me really registering that there's some sort of, so our skin is also providing us some protective mechanism by having this feedback as well. So these skin receptors also, so they don't only exist within sort of those contact surfaces. We think about the hands of our the palms of our hands or the soles of our feet, and we do a lot of sort of tactile exploration, as we sort of grab something within our bag and try and feel around for the bottom of my purse for, that object I'm looking for. I can use all that sensory information, and it's really highly densely populated in this sort of glabrous skin, we call it. But these skin receptors also exist in all of our skin, and particularly the skin surrounding our joints. It can help provide us with another sense known as proprioception. So proprioception is sort of our sixth sense per se, and that we are able to know have the ability to know where our body is in space, orientation wise, but also movement. So, and we don't need visual input to be able to perform certain tasks. So, for instance, I know how to, find my ponytail on the top of my head. I mean, if I theoretically wanted to, I could close my eyes and find my nose, or my fingers could find one another without me actually having to see my hands finding one another. So that's all due to different types of proprioception. And so we can also then use, integration of vision and proprioception. For instance, I can walk up, the stairs with a laundry basket in my hands, and I might use my visual information to help me, gauge the depth of each one of those steps. But if I'm holding the laundry basket and I physically can't see that step, I know where my legs are underneath me, because of this sense of proprioception. And it really has to do in terms of, there are a major component component of proprioception is sort of muscle spindle, which is it's a muscle receptor, sensory receptor that can give us, this sense of orientation. But skin compression and stretch will provide some sort of orientation of that joint and contributes to this awareness, such as our laundry basket going up the stairs. So, in fact, when I was back in my master's, we started to manipulate sensory inputs in healthy individuals, so we could start to understand what happens when they aren't working properly or when they aren't there at all. And so we anesthetize using a topical anesthetic with the top of the ankle joint in young healthy adults, and then we measured their walking patterns using 3D motion tracking. And we found that people chose to inherit a more conservative walking strategy by increasing that sort of minimal toe clearance when they were clearing the ground. But they did that by increasing sort of their ankle and knee angles to try and sort of elevate the limb overall. And this was the case for both overground and obstacle avoidance. And ultimately, it was demonstrating to us that we could remove sort of input or sensitivity of this sort of relatively small area of skin on the ankle joint, and we could create cascades of changes all the way up the limb to sort of change the walking pattern of how people were walking in healthy situations. So now imagine you close your eyes and you try to feel something beneath your feet and you feel nothing. Your feet are essentially blind. There might be remnants of some sensation, but nothing you can distinguish enough to be confident of what it is. And I'm sure you can imagine what happens when we're trying to walk, or when we're trying to balance or, do our activities of daily living. I'm trying to reach up to the top of that cupboard, but I have to lean over a little bit while I try and reach and, this thing above my head. And so, particularly if you're already living with some balance challenges as a result of Parkinson's, having this sensory information sort of hindered or unavailable to us could exacerbate, risks of falls and fall-related injury even further. And so, peripheral neuropathy is the damage to or impairment of these nerves within specifically the peripheral nervous system. And so, this is a sort of from my understanding, it's a newer sort of avenue of discovery in terms of things that are becoming more affected in Parkinson's than sort of the general population. And so, depending on where that damage occurs, it can affect sensory nerves. We can talk about, feeling and that provide that sensory information that we've been talking about. It can damage motor nerves, so that output from the brain or from the spinal cord to those muscles to cause, difficulties in muscle contraction. And then it can also affect autonomic nerves, which help control some of those more automatic functions like our heart rate, the digestive or stomach emptying, and even blood vessel constriction. So all of our blood vessels are controlled by autonomic nervous system to let us know, in, let's say, temperature regulation. A major component of skin circulation is thermoregulation. So keeping our core body temperature the same, but fluctuating our amount of vasodilation or vasoconstriction in our blood vessels in order to dissipate or conserve heat. So when we're cold, we have an increase in autonomic activity because it constricts those blood vessels to try and conserve our temperature and we don't lose that heat through some of our peripheral systems. But you can start to imagine all of these things will interact with one another and can, if we're starting to have dysfunction in some of these things, how it can affect sort of our balance and our mobility. And so, although it's most commonly found to be the consequence of diabetes, a recent review found that peripheral neuropathy is found in as many as 16% of people with Parkinson's, which is 2 times more common than that of the general population. And in fact, more recent work than that has found that as many as 55% of people with Parkinson's have some form of neuropathy if they start to also include some of this autonomic dysfunction, and looking at some of this more autonomic testings and components of neuropathy as well. So Interestingly, the route for more sort of investigation into Parkinson's came from, and as does many of these, I think, movements and progressions in Parkinson's sort of areas of research, is that it was from patient-reported sensory disturbances, particularly during that off medication state. And so, as of now, there does not seem to be any clear evidence for sensory fluctuations with dopaminergic medication. But it just highlights that if you are not talking to your healthcare professionals and, as a group and as a community and with researchers within the area, hearing all of the different things that are impacted or that are impacting your quality of life, it can sometimes end up turning into something even, I guess larger than we maybe thought it was, and that you're likely not alone in some of these situations. And so, it's always important that I think, and this has been stressed previously, of course, is that the motor impairments tend to be the central conversation in a lot of patients' interactions with their doctors. But of course, if you're having other sort of issues or concerns, please raise awareness to it, because I mean, there's, you just never really know, and then we can address those from there. So, some common symptoms of neuropathy, again, these will depend on what type of nerve is being affected, and that will dictate the type of symptom that people will experience. So it could be pain, sort of burning, itching. It will be specifically these C fibers, so these small autonomic fibers. And C fibers are a particular type of sensory receptor. You can sometimes get tingling, anywhere from tingling to numbness to actually even heightened sensitivity. So instead of being, lack of sensitivity, you're now getting, some sensation inputs that are even more sensitive than they should be, and it can actually turn into sort of a painful eventually, and that's called allodynia. And then, of course, muscle weakness is a potential outcome of that, particularly if it's affecting those motor nerves. And so these symptoms most often occur in the feet, but sometimes in the hands. And what folks will most often report is sort of this distal to proximal type of progression. So starting in the very tips of fingers and toes, and as the neuropathy progresses, we'll sort of have this stocking and glove type fashion as it moves up towards the wrist or the ankle. And so, again, it is progressive in nature. And so making sure that if we're starting to experience some of these symptoms, that, we can try and find the underlying cause. So, how is it diagnosed? So, the most common diagnostic tests to find out whether you have neuropathy, again, I sort of already alluded to this, it really starts with you talking about and taking inventory of your body and reporting any symptoms that you have to your doctor. So, unfortunately, at this time, neuropathy is not a current sort of battery within the tests that are going through, either, even in healthy aging or living with Parkinson's. So there are many different, sort of unlike just entirely relying on clinical tests, there are quite a few electrophysiological tests that we can confirm whether or not there is any sort of peripheral nerve damage. And so one of the most common ones is monofilaments. And so there's, as you can see pictured here, this monofilament is a nylon fiber, and it will, when applied to the skin, will sort of buckle at a known force. And so at that known force, it's sort of the intensity of stimulus that you should be able to feel if your skin receptors are functioning properly. And so they will apply it, sort of on several locations of the foot, and they might start to see where and whether you can feel this. And so that's kind of a very common clinical test. Through my particular work in my PhD, I looked at some of this sort of perceptual testing. And I mean, overall, it is a very gross sort of gross measure. And so it doesn't necessarily have the sensitivity to capture some of like the earliest manifestations. But it's definitely a cutoff for there is apparent nerve damage at this point by not being able to feel this monofilament sensation. So there's other sensory testings that more quantitative sensory testings and looking at like pain stimulus threshold. So can you feel the pain of a pinprick? Thermal sensory testing. So can you detect sort of cool and warm temperatures and how well you can sort of feel those different changes happening? And so and they can also do, some nerve conduction velocity studies. So they look at how quickly that nerve signal transmission, if we were to stimulate one of those mechanoreceptors in the skin of the foot sole, how quickly does that get measured or registered sort of further up into the nerve? And then, particularly if you have autonomic dysfunctions, and so that would, and autonomic neuropathy is suspected, they might actually take a skin biopsy and they would test for sort of the nerve density within that skin, and also look for the morphological changes. So is there sort of physical changes with the nerve, and does it still have its sort of nerve health in general? So again, it's always important if you feel like if you feel, this is always the punny thing, if you feel like you're having difficulty with sensations in your feet, the first step is to making sure that you can go through that testing process and confirm whether or not you are starting to experience any sort of neuropathy. So why do people with Parkinson's develop peripheral neuropathy? It's currently, I think, a big question mark. And it's definitely more than the average population, but it remains really unclear to date uh, whether peripheral neuropathy is a consequence of Parkinson's specifically, or it's emerging as some sort of secondary factor as a consequence of it. So some theories and evidence has emerged over the last few decades, but there's still not a clear answer at this time. So interestingly, and I want to bring this up first because with or without Parkinson's disease, as we age, there's a sort of general decreased bioavailability of specifically our B6 and our B12 vitamins, meaning that even by eating the foods that contain these nutrients, our bodies are not as good at absorbing them through the digestive system. So, as such, people often need to get some sort of supplementation. And I believe a B12 is usually delivered by like an actual injection a few times a year. So, it's always good to make sure that you're, the one thing is address the underlying cause. So, if you have the supplementation of these vitamins, in a lot of folks, it can drastically improve or even stop the progression of any of these neuropathy symptoms. So, staying up to date with your current blood work and making sure that you're, having all your nutrients is sort of step number one, with or without Parkinson's. There is some conflicting evidence for the toxicity of long-term use of levodopa. However, there are still individuals that are existing and that have, case studies that are experiencing peripheral neuropathy prior to even any medication use or very early on in their treatment course. So and some folks will even find that adequate dosing of their levodopa will improve some of their neuropathy symptoms. So it's really conflicting at this time, but there is still some of that existing evidence out there. Some studies have found that there are genetic links to whether or not you will develop peripheral neuropathy, specifically within the Parkin gene and this MTHFR gene. And then there's other evidence for denervation or neuronal cell degeneration. The etiology or the reason why that's happening in some of these is, it's similar to the cell loss that's happening in the basal ganglia, but it's occurring in the peripheral nervous system. And so they don't necessarily know at this time. But some folks have found sort of this alpha synuclein aggregate in some of these peripheral nerves, although more research is really needed to explore this relationship to unfold potentially why. But that's where we're sitting currently in our understanding. So, how can we treat neuropathy? I mean, most importantly, recognizing that it's not a disease on its own, and it's often the consequences of some other underlying cause. So the identification of that underlying cause is sort of that first line of treatment. So there are, but otherwise there are some medications, particularly those who are dealing with pain as a primary symptom, that can help alleviate nerve pain, but doesn't, stop nerve damage. For instance, the selective serotonin or norepinephrine reuptake inhibitors, antidepressants, tricyclic antidepressants. Some folks will use more topical treatments like a capsaicin cream. So capsaicin is it's sort of the active ingredient in hot peppers. And so you get that sort of A535 sort of burning sensation. And so some of the research will show that this capsaicin cream can increase what's called substance P. It's a neurotransmitter that can be absorbed through the skin, and that can have central sensitization within the spinal cord. It can actually change pain thresholds. There's also some literature to suggest that the capsaicin cream is almost like a sensory masking. So they're providing other types of sensory input, which can almost block. It's almost like your brain starts paying attention to that sensation rather than the pain itself. And then like a lidocaine cream or a patch, which is just like a sort of a topical analgesic to help sort of numb those nerve fibers. Some folks have used injections such as Botox to help sort of block with this pain. And then there's other more sort of non-pharmacological approaches like electrical nerve stimulation that can, particularly for those with autonomic function and like urinary incontinence, for instance, due to neuropathy, this electrical stimulation can work, but you can almost think of it as like similar to a TENS. It's just not actually causing muscle contraction. So we're getting this percutaneous nerve stimulation similar to the capsaicin cream. It's providing some sort of sensory input that might be blocking sort of the pain signal up above. Otherwise, improving circulation. So sitting too long, avoid sitting too long. As I ask you to sit and listen to this webinar, I'm being hypercritical, but so sitting too long, part of that reason is it's really easy for the blood to get down to our feet, and it's harder for it to go against gravity to get it up. So you might have heard, when you're on an airplane, make sure you get up because blood can pool in your feet if you sit for too long. And so let's say you're stuck at a desk doing a talk for an hour and you have to sit. Other alternatives are doing things like ankle rotations and contractions to be able to try and almost pump that blood. And so you can think of your heart's going to pump your blood through your body. And it has a harder time getting, of course, from the bottoms of your feet back up, but your calf almost acts as this manual pump. And so when we are, exercising or increasing our physical activity, it contributes to that improvement of circulation as well. So because that circulation has a direct, and so some of my PhD work was looking at how measuring cutaneous blood flow and how it influences some of these skin receptors in a healthy population. There's some evidence to suggest, right, if we can improve circulation, we can actually sensitize these receptors a little bit more. So some of my future work will be looking at and within this lab, and we're sort of working on some projects to look at how we can improve sensation in the periphery of those with Parkinson's, and whether it can have sensory effects and then ultimately help with balance and postural control. So how can I take care of my feet? I mean, the one thing we don't necessarily think about it, but check them every day. So you can imagine if you're already living and dealing with neuropathy, we don't have that sensation. And so one of the protective sensations that we, haven't really discussed that much today is the sensation and the protective sensation of pain. If we have injured our foot, where we have a sore on our foot, we would normally feel that level of discomfort, and it would prompt us to look at our feet. If we don't have that sensory feedback, we might have to, we might have a sore or an injury that we're not even necessarily acutely aware of. So it's important to inspect our feet every day, monitor any sort of sores or injuries for sources of infection. Your main sort of key components of infection is sort of red, hot, if there's any sort of discharge, all of these indicate potential signs of infection. So it's feeling for those types of things and looking for those types of things visually every day. Um, Making sure things, even things like taking care of the skin of our feet by adequately moisturizing them. So especially with these winter months and our skin can dry out, it might need supplemental moisturization. With the caveat of we should never moisturize between our toes because that moisture can sit there and actually cause skin breakdown by too much moisture. So it's finding the balance of trying to moisturize, particularly the soles of the feet where we get a lot of those calluses, and keeping those and after a shower adequately drying them. So if you can't reach your feet and there's in terms of flexibility issues, put a hair dryer on low. And you can help dry your feet after a shower, particularly between your toes, so that there's not also moisture sitting between there, because that can be a growth spot for bacteria and for fungus, and so that can breed. And particularly if there's a small cut, it's an easy way to enhance the chance of an infection. Remaining active, and so we can't stress this enough. Exercise will improve the circulation of our feet. It uses that sensory information on a regular basis. And more than anything, just remember that consistency is way more important than capacity. And even if you don't really feel up to it that day, or it's a particularly snowy day, can you do just a little bit in your home and to just try and keep up that routine of consistency? Eating a well-balanced diet, so maintain, particularly managing blood sugar and cholesterol, which has, a direct impacts on circulation and therefore nerve health. So you can imagine, so we haven't, directly talked about it a little bit, but those nerves have their own blood supply to be able to keep healthy too. And so that blood supply needs to be, if your blood sugars are too high, blood sugar can create sort of almost like a increase in viscosity of your blood. And so it makes it harder. It's almost thicker and syrupy, you can imagine. So it makes it harder to flow, particularly through these really particular, the small microvessels. And so keeping our good blood sugar and our cholesterol can help that circulation. And vitamin supplementation. So discuss with your doctor if you haven't just figured out or know yet whether or not you have adequate B12 within your body, and then of course wearing good shoes. So I'll take a couple minutes here, the anatomy of a good shoe, and I've taken this from sort of Harvard University Health Outreach. They have a nice little article, which I can always post in the link to the chat. But really, the idea is that you're looking for something with good cushioning, so it has good shock absorption support and a nice thick sole to be able to help disperse and alleviate pressures. Having any sort of ankle stability will help keep with, and helps support the ankle. Looking for materials like that have good tread. So having good tread. So even if our skin sensation isn't the best, if we can, have good tread, it will minimize any sort of slips and falls. And then I really can't, I would think of all the dimensions is making sure that you have enough room in your toe box, so the width of the shoe. And so if we also think about not even just protecting our foot from, let's say stepping on something sharp and having a nice thick sole to be able to protect us from doing so, but having enough space within the shoe. If our feet become too crowded, they start to rub against one another and it can cause blistering and emaciation. So that skin breakdown can happen just from too much rubbing. So other things, other tips to just in general. So review your closet, look through your shoes, throw away old shoes that sort of don't meet these requirements, anymore. If you are going to purchase a new shoe, always do shoe shopping late in the day. And that's because your feet swell as the longer through the day, the longer that you're on them. And so you want to make sure that they feel comfortable to you sort of when your foot is at its largest, and that you can always adjust that, make it tighter with laces if you need to sort of earlier on in the day. Make sure there's lots of wiggle room and good tread, a wide shoe box, and you might want to consider white socks, particularly. It will just show any sort of, if there's any discharge or bleeding or anything, it's going to show up on a white sock, and you'll probably notice that more than, let's say, if it was within a black sock or a darker colored sock. So just sort of general tips in taking care of our feet. I mean, our feet are what get us around. Our feet are what allow us to have independence and mobility. And so taking care of them means you're taking care of sort of your overall general health as well. So with that, I mean, that's all I have on that topic, and I'm happy to take any questions. But before I do, if I want to take just a few minutes of some of the current ongoing studies that we have in our lab and do a little soapbox pitch. So one of the studies that we have going on is examining the impact of stress and anxiety on physical capacity to control mobility. And so within this study, we actually do some sensory proprioception, and some of the data that we're looking at now is relating how that sense of proprioception and relates to our balance control in Parkinson's. And so people both with Parkinson's and healthy controls are needed for this work. There's an online questionnaire to perform before you come in, and then you come in and we use virtual reality. So here's one of our scenes here to sort of manipulate aspects of the environment to be able to look at how it changes our walking. And we measure things like heart rate and sweat rate and looking turns of arousal, because there's also some evidence that we're interested in navigating down the road is how does that amount of arousal or anxiety influence our ability to know our proprioception and sensitivities in space. We also have we're part of a bigger international group with the Movement Disorder Society that we're validating a new measurement tool for posture and gait in Parkinson's disease. So this is about a 1 hour session. We often actually pair these two studies together and complete them all within actually the same 3 hour period, because there's a lot of overlap of some of the assessments that we do. Um, and so what we're doing right now is hopefully validating a new test for balance that's specifically related to challenges that deal with posture and gait. And then the last one that we have going on is specifically for freezing of gait. And we're validating this new clinical assessment tool to look at the severity of freezing. So we're both looking for both people who experience freezing, so freezers and non-freezers. And so part of it is getting hooked up with some movement sensors, doing some walking conditions that provoke freezing, both off and on medication. And then we send you home with some of these movement sensors so that we can monitor some of your movements at home in your home environment. And then we have you come back a week later and sort of repeat this testing. And so some of this ties into how we're looking at freezing and potentially using other sensory provocations to help reduce freezing in the future as well. So these are our current ongoing studies. This is our sort of current lab group, our funding sources. And if you're interested in participating in research, there's a few ways that we can do that. If you wanted to join our contact list, you can either send me an email, you can go to our website, or you can use this QR code. And so by joining this contact list, all it really does is give us the consent to connect with you via email or phone, to be able to talk about some of the research that we're doing and reach out and ask and inquire whether you would be like to be a part of it. And so I think that's everything that I had, Robin, and I'd love to take any questions.
Okay, I'll just stop recording.